Postprocedure Angiograms and Hemostasis. Remove guidewire for final images after additional intracoronary. Nitroglycerin. Angiography with guidewire in place may disguise intimal flap or dissection. Femoral angiography before vascular closure device selection. Perform right anterior oblique view for right femoral artery and left anterior oblique for left femoral artery. Alternatively, if not suitable for the closure device, secure arterial and venous sheaths in place. Remove in 4 hours when ACT less than 150 seconds. These considerations do not apply to radial artery access. No post-procedure heparin infusions unless there are highly unusual circumstances. Post-procedure care, recovery area. Nurses should begin patient teaching on hospital course and bleeding problems, late complications, and restenosis. The PCI team notifies. Departments, intensive care or other appropriate patient care area. Operating room, and surgical team on stand down. Post-procedure laboratory and ECG results are obtained. Post-procedure care, step-down area after PCI, chest pain may occur in as many as 50% of patients. ECG evidence of ischemia identifies those at significant risk of acute vessel closure. When angina pectoris or ischemic ECG changes occur after PCI. The decision to proceed with further interventional procedures, CABG, surgery, or medical therapy should be individualized, based on factors such as hemodynamic stability, amount of myocardium at risk, and the likelihood that the treatment will be successful. Following PCI, the hospital care team should monitor the patient for recurrent myocardial ischemia, puncture site hemostasis, and contrast-induced renal failure. Post-PCI care, medications. Order aspirin, 325 mg orally daily. Give clopidogrel, 600 mg loading dose and 75 mg per day orally, at least 4 weeks after stenting with a bare metal stent and 12 months with a drug-eluting stent. Initiate statin drugs if not already prescribed. Restart or initiate antihypertensive or antianginal medications depending on the patient's clinical needs. Resume prior medications for other conditions, e.g., GERD. Appropriate secondary atherosclerosis prevention programs should be started involving adherence to recommended medical therapies and behavior modifications to reduce morbidity and mortality from coronary heart disease. Patients with renal dysfunction and diabetes should be monitored for contrast-induced nephropathy. In addition, those patients receiving higher contrast loads or a second contrast load within 72 hours should have their renal function assessed. Whenever possible, nephrotoxic drugs, certain antibiotics, non-steroidal anti-inflammatory agents, and cyclosporin and metformin, especially in those with pre-existing renal dysfunction, should be withheld for 24 to 48 hours after PCI. After discharge, the patient then returns to activities of daily living within 1 or 2 days. Factors preventing rapid return to work include access site complications and persistent symptoms. A functional ischemic testing evaluation for patients with multivessel coronary angioplasty or incomplete revascularization after angioplasty will indicate the limitations, if any, on work status.